All right, let's welcome Gigi Colombini, is the founder of the Institute for Hope and Human Flourishing, a long-term expert in the area of suicide prevention and mental health, as well as a long-standing social worker here. Thank you so much for being here.
Thank you for having me, really.
I want to begin by looking at just suicide prevention nationally and how it dovetails into mental health. I want to come to COVID later because that's an issue. I've been reading a lot on that lately. But just begin on a national scale here. Your take in terms of where we are relating to suicide. I've been reading a lot about this lately.
Yeah. Probably about 25 years now, the Surgeon General put out back in the late 90s sort of a call to action on suicide prevention.
Right.
Mobilizing people all across the country to do something about this problem of suicide. It has been the 10th leading cause of death for a couple of decades now, till COVID hit. That sort of moved things around. But this idea that it needs our attention, and lots of attention has been given to the awareness, to identifying people who might be suicidal, and that has definitely increased. So we are finding that many more people are accessing mental health services over the years in the effort to deal with this problem of suicide. It's definitely a great thing, and the solution doesn't stop there. While we've identified people who need help, we have yet to teach the helpers what to do, because we're still functioning from an old model.
So let's talk about that model then. If those who are supposed to render help are not properly trained, where those that left us on the question of suicide prevention and of course the subsequent mental health issues as well.
Right, yeah, this model being that the first line of defense is hospitalization, essentially.
Okay.
Which is really scary, which will keep most people, would keep me from saying, hey, I'm thinking about suicide, because ideally we're working with somebody when they're just thinking about suicide and not fully intent or taking action on suicidal thoughts. So the model being that we're not sure what to do about it yet, or we're not acting on it. So then let's hospitalize them to keep them safe, and then see what happens.
Well, what do you think is wrong with that model?
Statistically, what's wrong with them? We can even just look at the numbers, and the numbers show us that somebody who goes to the hospital for being suicidal statistically is more suicidal when they leave. It's
Really?
Actually a problem, and they don't get the care they need. It may stabilize, especially somebody who is acutely suicidal, who's actually intent on.
Right.
Well, sure, they belong there.
Right.
But pretty much not the rest of the people. It's about addressing a lot of pain, a lot of desperation, and that can be handled in an outpatient setting with clinicians who are well trained in having the conversation. Similar to the way that in the past, substance use treatment wasn't really treated. It was thought of as you just stop using, right?
Yeah.
And then treatment centers began to pop up, and they were more inpatient-like, although certainly led by those with wealth, so they were nice. But then it became like outpatient settings began to help people who were needing treatment for substance use. I see suicide prevention, suicide treatment moving in that same direction, where we need to start thinking about there's this problem that can be addressed in outpatient, and it's connected to all these things, because certainly somebody who's in a substance use treatment program, there's other reasons they're there as well.
Yeah,
So,
yeah.
And we're just not doing that yet.
So 25 years ago, 25 years later, what do you see? Do you feel that we're a step back forward, in terms of suicide prevention?
Well, we're certainly forward in terms of being able to better identify somebody who may be suicidal.
Right.
We're just not yet at a place where, once identified, those people are really getting good help that they need.
Okay.
At the Institute for Hope and Human Flourishing, our focus is on having our clinicians are all well trained and being able to get somebody through a suicidal crisis, and then ultimately get to all the underlying things that got them there, because that's what's really going on.
Right.
But without managing the suicidal crisis, again, much like substance use, if somebody's using all the time, you can't get to the underlying stuff. So you manage the symptoms of suicidality and get them to a place where they can start looking at what's so painful that they'd rather die than go through this.
Yeah, yeah. I mean, what is the biggest challenge, though, at the Institute for Hope and Human Flourishing that you see in terms of just dealing with this issue that has always remained a constant phenomenon?
Yeah, it's probably the same that's out there for other clinics. We're just all really busy now. And you mentioned,
This is from COVID?
From COVID.
The pandemic? Let's talk about that.
Mental health is overwhelmed. So any stressor going on for a long period of time becomes a significant problem in people's lives, and collectively around the world. It's not even just the nation. We've had this stressor of, the reality of COVID and so much death, but then the unknowns are pervasive and they continue on.
Right.
And life isn't all the way back to normal yet. And so all this long-standing stress add to other things that are going on in people's lives have caused a lot of mental health distress and people accessing the system because somehow in that process, to some degree, our insurance companies allowed for people to have easier access to mental health treatment. Mm-hmm. But mental health, the numbers, we just weren't prepared to do that.
I had Detroit Police Chief James White on this program a couple of weeks ago, and mental health came up in terms of crime prevention and all of that, the calls that they're making. But given that COVID has exacerbated this issue, do you feel that clinicians who are trained, who are in this area, people like yourself, do you feel that you are equipped to take on this added pressure that we're getting from COVID in terms of mental health challenges, and to the point of folks who are on the edge when it comes to suicide?
Certainly our clinic, more than most, more than any that I know, frankly, because I often get asked for referrals closer to people's homes and I just don't know anybody who's really doing it in the way that we're approaching it. But mental health in general isn't prepared for the numbers, the sheer numbers. Everybody that I know that's any good at all is completely full in their practices, which is really sad. It's
but
so
that's
much in healthcare, right?
that is serious. If in fact there are no intakes anymore because people are inundated.
Right. Or, for me, almost even worse, the intakes that do happen are from unskilled clinicians, which can leave somebody who's hopeless and suicidal feeling like there's no help, and that really is the answer. So that's really becomes a problem in terms of suicide.
So this unskilled clinicians, you feel like the field of suicide prevention, mental health is proliferated with unskilled clinicians, or do you feel that it is a serious problem that requires attention right away?
It's a serious problem that requires attention. It requires training. There's no requirement for us in the mental, the leading cause of death in my profession is suicide, right?
Right.
And we're not required to learn about it. There's a little blurb at some point in undergrad and maybe a little bit in graduate school, but beyond that, no one's being taught formally how to work with suicidal patients. It's a real problem, and so they feel at a loss and uncertain, which creates hopelessness in the patient, right? Both the clinician and the patient are scared about what to do instead of enough training. And I do this and we do this. I come from a crisis center background, answering a suicide hotline. There are models out there that work effectively, that easily translate into the clinical setting, that once taught and practiced with enough time, we have confident clinicians who can take on patients who may be suicidal and get them through the suicidal crisis and then just be working on the stuff that's got them so painful. I often feel like it's not rocket science, but people just aren't stepping there because they're afraid to, and that's a problem
Yeah. But going back to the lack of training thereof in terms of leaving people who are suicidal with untrained clinicians and the rest and so forth, what do we need to do? What needs to happen? Is this a funding issue? Is this an issue of the way the structure is set up, that you're not required to be trained in suicide prevention to talk to somebody who is probably on the verge of committing suicide? What needs to happen here to reinvent things?
Yeah. Part of it, we're going to watch our language. Committing suicide is not a way to say it in terms of you commit a sin or you commit a crime, right?
Okay.
So somebody, in terms of dying or dying by suicide, attempting suicide, right? So we need to sort of hold it differently.
Okay.
I get that all clinicians out there aren't good with all the different situations.
Right.
I certainly wouldn't take on a substance use treatment type. A lot of patients who are deep in addiction. That's just not my area of specialty. So I feel like it needs to be clinicians who are more comfortable with difficult things, like suicide, that in a way get trained sort of like there's all these letters that go with substance use treatment, clinicians, and that we need to have a model go towards that. In the Institute for Hope and Human Flourishing isn't just an outpatient mental health clinic, it's a training center too, so that people can get trained on how to do these things. And I think ultimately we're probably going to go towards some sort of a specialty, so that if that's going on,
just like the field of medicine, I mean, there's a specialty.
Right, there's all kinds of specialties, and not everybody knows how to do everything, and they don't need to.
Right.
But there's a lot of people who come from like have worked maybe in hospitals and that have worked a lot with suicide, right? And so then they come out with more comfortability than others. And it's absolutely possible. We're just not going there yet, and we need to, because it's a big problem.
So I want to also talk about then the training facility. You said the Institute for Hope and Human Flourishing is not only an outpatient clinic, but it's also a training facility. Talk about that process, though, in terms of what stands out in your training when people come in for training. What do you realize from the candidates that you train who would go out to provide services to those who may be or could be suicidal?
So definitely noticing that there are some who are more natural at it, that they get it, that they don't mind it, stepping into those really difficult and sometimes scary conversations, because we are talking about life and death, but enough to navigate them to the help that's needed. So the training allows for that. Like sometimes I've taken classes and I'm like, yep, that's not for me. So we get to discern for ourselves, but it also, the way I provide training, it comes with lots of practice. So you're not just left on your own. You don't just take a 12-hour course, 2 or 3 day course, and then go out on your own, because that's a lot to hold. There's support with, practice afterwards and follow up with the clinicians, which is ideally the best way to take on something really new. Because you may not, if you go back into your own clinic, other people haven't been trained. They don't know. You can't go to your supervisor and say, how am I doing this right? Because they haven't had the training either. Because it's really new.
What is interesting, though, as we're talking about this, I don't hear this side of the suicide debate, the untrained clinicians, and those who you think need to have the specialty to attend to a crisis like this, because like you said, it's a life and death, and I feel like perhaps it takes a certain kind of individual who ought to be specialized in that space to be able to attend to somebody who might be, on the verge of that kind of crisis in their life.
Right. I mean, it's two-sided. It's a very interesting thing still. Of course, the stigma around suicide prevents even, like, if I'm saying I'm a clinic that specializes in suicide, there's this presumption that anybody I'm talking to is actively suicidal.
Okay.
So there's a bit of fear about getting that label, because we're still functioning in this world, and there's a reality.
We need to break the stigma.
There's
the stigma needs to be removed.
There's the stigma piece for sure.
Right.
On both ends. I mean, I've been doing this kind of work for 30 some years, and I'll even attend events that are suicide prevention events, and my patients will be there, and they won't say that they've received services from me. There's this disconnect in it, in the stigma that makes it really hard. So this idea of having clinics that are focused on the ability to provide those services, I think is a big part of it. And it's a funding issue too.
You feel that the stigma leads to isolation too, once people, think that, oh, this individual may be, then, people recoil.
Possibly, but it's also been a very interesting thing. The relief I see, I don't think I've ever seen it, that a family or an individual, when they sit down with me and get to say that, and to say, I'm having thoughts of suicide, whatever level it is, or I've lost, or even I've lost a loved one to suicide. It may not even be them, it's somebody that they've lost. The relief of being able to talk with somebody who understands and knows it deeply, it's such a weight off their shoulders. So there's not the recoiling. It's like when somebody sort of goes into that with them.
It's a sense of relief.
A huge sense of relief, like, oh, somebody's got me, which is a big deal.
So finally, let's talk about the joy of what you do, because I've watched you for a long time, and this is almost like the ministry for you. I mean, you're the founder of the Institute for Hope and Human Flourishing. Let's talk about that in your final comments. What gives you joy? What makes you do this?
It comes from a background for myself as a kid, struggling with these things as well. But I have seen hope over and over and over again. People come back to life, essentially, feeling so hopeless, imagining they were never going to feel different in the future ever. And I'll talk to them years later, and they're like, I never thought that I could come back and have me again and get back to life and my dreams and all of it. I see it time and time again. A suicidal crisis is not forever. It's a transient state. It's it's a crisis, and people move through it. And when getting to work with somebody who knows what they're doing, they can move all the way through it and begin flourishing, not just being okay, but actually come back to their life that they get to create, the life of their dreams.
All right. Well, thank you so much for being here.
Thank you so much, Bankole.
All right. Gigi Colombini, the founder of the Institute for Hope and Human Flourishing here in Michigan. We'll be right back with more on Sunday Nation. Stay with us.